Okay, guys, so we're just going to do a real quick hematology overview, and then I will go into hematologic problems. So the hematology is the study of blood and the blood-forming tissues. This includes the bone marrow, blood, spleen, and lymph system. A functioning hematologic system is needed to support our ability to transport oxygen, carbon dioxide, as well as maintain intravascular volume, coagulate blood, and combat infections. So the bone marrow is the soft material that fills the central core of bones and is where blood cell production or hematopoiesis occurs. There are two types of bone marrow: yellow, which is the adipose, and red, which is the hematopoietic or hematopoietic, and where blood is what actively makes blood cells. There are three types of blood cells: red blood cells, white blood cells, and platelets. And they all develop from a common hematopoietic stem cell, which is an immature blood cell that is able to self-renew and differentiate into hematopoietic precursor cells. The bone marrow responds by a negative feedback system to the need for specific blood cells by increasing that cell's production. Blood is a type of connective tissue that has three major functions: transportation of oxygen from lungs to cells, of nutrients from GI tract to cells, of hormones from endocrine glands to tissues, and of metabolic waste products from cells to lungs and liver and kidneys. It also functions to regulate fluid and electrolyte balance, acid-base balance, intravascular oncotic pressure, and body temperature. And lastly, it functions to protect by maintaining homeostasis of blood coagulation and by combating invading pathogens. The components, the two major components of the blood are the plasma and the blood cells. About 45% of blood is composed of red blood cells, white blood cells, and platelets, while the other 55% is made up of plasma. Plasma is composed mostly of water, but also contains proteins such as albumin, globulin, and clotting factors, as well as electrolytes, gases, nutrients, and waste. The term serum refers to plasma without the clotting factors. Erythrocytes, or red blood cells, are flexible cells with thin membranes which enable them to pass through tiny passages such as capillaries and to facilitate the diffusion of gas. Their main job is to transport oxygen and carbon dioxide, as well as to maintain acid-base balance. They have an average lifespan of about 120 days. Erythropoiesis is the process of red blood cell production, which is stimulated by hypoxia and is controlled by erythropoietin, which is the glycoprotein growth factor that is made and released primarily in the kidney. Erythropoietin stimulates the bone marrow to increase erythrocyte or red blood cell production. Many essential nutrients are necessary for erythropoiesis. These include protein, iron, folic acid, vitamin B12 or cobalamin, riboflavin or vitamin B2, pyridoxine or vitamin B6, pantothenic acid, niacin, absorbic acid or vitamin C, and vitamin E. Erythrocyte production is affected by endocrine hormones such as thyroxine, corticosteroids, and testosterone. Hemolysis is the destruction of red blood cells by monocytes and macrophages, which normally occurs in the bone marrow, liver, and spleen. Like red blood cells, white blood cells also originate from stem cells. They then eventually reside in the thymus or secondary lymphoid tissues, such as the spleen, lymph nodes, and Peyer's matches. There are 5 different types of leukocytes, each with a different function. This is just a picture of the neutrophils. So neutrophils, the primary function of granulocytes in general is phagocytosis, or engulfing any unwanted organisms by digesting and killing them. Neutrophils are the first at the site of acute infection or inflammation and are the most common type of leukocyte. Eosinophils engulf antigen-antibody complexes, which are formed during allergic reactions. Basophils, which make up less than 2% of all white blood cells, have cytoplasmic granules that contain chemical mediators such as heparin and histamine. Basophils respond to stimulation by an antigen or tissue injury by releasing substances from granules in response. And they are what is responsible for the allergic and inflammatory reactions. Granulocytes include lymphocytes and monocytes. Lymphocytes are B cells and T cells, and they form the basis of cellular or humoral immune responses. Monocytes account for only about 4 to 8% of white blood cells, and they are phagocytic cells that ingest small or large masses of matter such as bacteria, dead cells, tissue debris, and old or defective red blood cells. These cells are only present in the blood for a short time before they migrate into tissues and become macrophages. Macrophages interact with lymphocytes to facilitate humoral or cellular responses. Thrombocytes, or platelets, primary function is to initiate the clotting process by producing an initial platelet plug at the site of an injury. Platelets must be available in sufficient numbers and must be structurally and metabolically sound for blood clotting to occur. Normal clotting mechanisms. Hemostasis is the term we use to describe the arrest or stopping of bleeding. The process is important in minimizing blood loss when various body structures are injured. The sequence of events is vascular injury and endothelial exposure, which causes a local vasoconstrictive response. Then there is the platelet adhesion, followed by platelet activation. So the platelets change shape and allows them to bind to adhesive proteins. The release of platelet granules recruits and activates other platelets, clotting factors, and growth factors, which then causes platelet aggregation and a platelet plug to form. Anticoagulation may be achieved by antithrombin activity, vessel platelet activity, and fibrinolysis. So after the platelet has formed, there is clot retraction and dissolution, either by procoagulants or anticoagulants. Antithrombin keeps blood in a fluid state by antagonizing thrombin. The fibrinolytic system is the second means of maintaining blood in its fluid form. It results in dissolution of the fibrin clot. The fibrinolytic system is initiated when plasminogen is activated into plasmin. Thrombin is one of the substances that can activate the conversion of plasminogen to plasmin, thereby promoting fibrinolysis. The plasmin attacks either fibrin or fibrinogen by splitting the molecules into smaller elements known as fibrin split products or fibrin degradation products. If fibrinolysis is excessive, the patient is predisposed to bleeding. The spleen is the largest secondary lymphoid organ, located in the upper left quadrant of the abdomen. It has 4 major functions. Hematopoietic, through its ability to produce red blood cells during fetal development. Filtration, through the removal of old damaged red blood cells, removal of hemoglobin from red blood cells, and returning of iron components to bone marrow for reuse, and filtering of bacteria, especially encapsulated organisms. Third function is immunologic. It contains a rich supply of lymphocytes, monocytes, and stored immune globulins. And lastly, it functions to storing red blood cells in approximately 30% of the mass of total platelets. A person who has had a splenectomy has higher circulating levels of platelets than a person who has a spleen, because those platelets are not being stored. The lymph system consists of lymph fluid, lymphatic capillaries, ducts, and lymph nodes. It carries fluid from interstitial spaces to the blood. It is through the lymph that proteins and fat from the GI tract and certain hormones can return to the circulatory system. It also returns excess interstitial fluid to the blood. Lymph fluid increases when interstitial fluid increases. when too much interstitial fluid develops or when something interferes with resorption of lymphedema develops. The primary function of lymph nodes is filtration of pathogens and foreign particles that are carried by the lymph nodes. The liver also functions as a filter. It's able to produce all of the procoagulants that are essential to homeostasis and blood coagulation. Frequent blood transfusions or diseases that cause iron overload can result in more iron than tissues need. Hepcidin is produced by the liver and is a key regulator of iron balance. The synthesis of hepcidin is stimulated by iron overload or inflammation. Hepcidin reduces the release of stored iron from enterocytes in the intestines and macrophages. Thus, when iron is deficient, hepatocytes produce less hepcidin, releasing stored iron and increased dietary absorption of iron. Gerontologic considerations: there is a gradual physiologic process of cell loss and organ atrophy that occurs with aging and leads to some changes in the hematologic system. Bone marrow mass and cellularity decrease, bone marrow fat increases. Although the older adult is still capable of maintaining adequate blood cell levels, the reserve capacity leaves the older adult more vulnerable to possible problems with clotting, oxygen transport, fighting infection, especially during periods of increased demand. Hemoglobin levels begin to decrease in both men and women after middle age. Healthy older adults are not able to produce reticulocytes in response to hemorrhage or hypoxemia, as well as they did when they were younger. Platelets may have increased adhesiveness, and osmotic fragility of red blood cells is increased in the older person, which can manifest into easy bruising. The total white blood cell count and differential are generally not affected. However, decrease in lymphocyte function does occur. So some diagnostic studies of the hematologic system. The most direct means of evaluating hematologic system is through lab analysis. The CBC, or complete cell count, involves several lab tests, each of which serve to assess the three major blood cells formed in the bone marrow. A peripheral smear is used to look at morphology, or shape and appearance of blood cells. Although the status of each cell type is important, the entire system may be disrupted by diseases as well as treatment of diseases. When the entire CBC is suppressed, a condition termed pancytopenia, which is a marked decrease in numbers of all of the blood cell types. So white blood cells, red blood cells, and platelets exist. The normal values of red blood, Normal values of some red blood cell tests are based on body mass, thus they are different for men and women. Anemia, hemorrhage, and states of hemodilution, such as those that occur when fluid volume is excessive, can cause reduced red blood cell counts. Increases in red blood cell tests found in polycythemia or states of hemoconcentration can develop from volume depletion or dehydration. Hematocrit determines the percentage of red blood cells compared with total blood volume. The hematocrit value is generally 3 times the hemoglobin value. Red blood cell indices are special indicators that affect the red blood cells' volume, color, hemoglobin, saturation, and can provide insight into the causes of anemia. Erythrocyte sedimentation, or SED rate, measures the sedimentation or settling of red blood cells and is used as a non-specific measure of many diseases, especially inflammatory conditions. White blood cell elevation does not necessarily predict the severity of illness, but can provide clues about the etiology of such problems such as infection, inflammation, tissue injury, and malignancies. Low white blood cell counts, less than 4,000, are associated with bone marrow depression, severe or chronic illness, and some types of leukemia. Certain types of leukemia are also more likely to produce extremely high white blood cell counts. The differential white count identifies the percentage of different types of white cells within the circulating blood. The differential is considered significant because it is possible for total white blood cell count to remain normal despite marked changes in one type of leukocyte. When infections are severe, more granulocytes are released from the bone marrow as a compensatory mechanism. To meet the increased demand, many young and mature neutrophils are released into circulation. More mature neutrophils are called polymorphonuclear segmented neutrophils, or SEGs. Together, bands and SEGs comprise the absolute neutrophil count. The usual laboratory procedure is to report the white blood cells in order of maturity. When the bone marrow does not produce enough neutrophils, neutropenia occurs. Neutropenia is a condition when the absolute neutrophil count is less than 1,000 cells. It is the result of a number of disease processes such as leukemia or bone marrow depression, and is associated with a high risk of infection and death from sepsis. Platelet count, normal, is between 150 and 400,000. Thrombocytopenia, or low platelets, occurs when there are below 100,000 and increases bleeding risk and risk of spontaneous hemorrhage. Thrombocytosis is excessive platelets, so greater than 400,000, and is a disorder that occurs with inflammation in some malignant conditions. The most likely complication related to thrombocytosis is excessive clotting. Blood typing and Rh factor, the absence or presence of one or both of the two inherited blood group antigens, is the basis for the four blood groups, A, B, AB, and O. Blood group antigens A and B are found only on red blood cell membranes. Blood group A has A antigens, group B has B antigens, group AB has both antigens, and group O has neither A nor B antigens. The Rh system is based on a third antigen, D, which is also on the red blood cell membrane. Rh positive people have the D antigen, whereas Rh negative people do not. As a result of transfusion therapy or during childbirth, an Rh negative person may be exposed to Rh positive blood. After exposure during childbirth, the mother forms an antibody, anti-D, which acts against Rh antigens. In subsequent pregnancies, the mother's anti-D antibodies can cross the placenta and attack the red blood cells of a fetus who is Rh positive, thus causing hemolysis of the red blood cells. This is why pregnant Rh negative women receive RhoGAM injections to prevent anti-D antibodies from forming. So blood typing and Rh factor is very important when we're talking about transfusing blood transfusions and transfusion reactions, which we'll talk about in a little bit. Iron metabolism. A major factor in healthy functioning blood is iron, which is obtained from food and dietary supplements. Most is bound to the heme in blood as hemoglobin and in muscle as myoglobin. And the other 1/3 is stored as ferritin and hemosiderin in the bone marrow, spleen, liver, and macrophages. When stored iron is not replaced, hemoglobin production is reduced. Transferrin, which is synthesized in the liver, serves as a carrier plasma protein for iron. The degree to which transferrin is saturated with iron is a reliable indicator of iron supply for developing red blood cells. There is normally very little iron loss, except from blood loss when iron is recycled. Laboratory tests used in evaluating iron metabolism and differentiating anemias include measuring serum levels of iron, total iron binding capacity, serum ferritin, and transferrin saturation. Total iron binding capacity provides a measurement of all proteins that act to bind or transport iron between tissues and bone marrow. Transferrin saturation is a better indicator of the availability of iron for erythropoiesis. Under normal conditions, the serum ferritin concentration correlates closely with body iron stores. Biopsies are another diagnostic tool for the hematologic system. This includes bone marrow biopsies, which involves aspiration or can be aspiration and biopsy to evaluate the components within the bone marrow. The preferred site for aspiration is the posterior iliac crest, as shown in the picture. After a bone marrow aspiration and biopsy, the site must be assessed frequently on the day of procedure and for several days thereafter, and patients can experience some discomfort and pain and require mild analgesics. Lymph node biopsies involve obtaining lymph tissue for histologic examination. This can be accomplished either by an open biopsy or a closed needle biopsy. Only a positive result is adequate for confirming a diagnosis. A negative result may be a reflection of the sample and is not considered a diagnostic indicator. Testing for specific genetic or chromosomal variations in hematologic conditions is often helpful in assisting diagnosis and staging. And these results also help to determine treatment options and prognosis. So moving on to problems with the hematologic system. The first one we're going to talk about is anemia. Anemia is a deficiency in the number of red blood cells, or the quantity and quality of hemoglobin, and or the volume of packed red blood cells. It is a common condition with many causes, such as blood loss, impaired production, and increased destruction of red blood cells. Blood loss can be from acute causes such as trauma or GI bleed, as well as chronic causes such as liver disease or duodenal ulcers. Decreased red blood cell production can be from deficient nutrients such as iron or folic acid, from decreased erythropoietin production in the kidney, or from decreased iron availability in the liver. Increased red blood cell destruction can be caused by medications, trauma from incompatible blood transfusion, and from diseases such as symptoms of anemia are caused by body's response to tissue hypoxia and vary based on the rate of development, severity, and presence of coexisting diseases. Mild anemia, or hemoglobin between 10 and 12, is typically asymptomatic. If symptoms do develop, it's usually because the patient has an underlying condition or because as a compensatory response to exercise. Symptoms can include palpitations, dyspnea, and mild fatigue. Moderate anemia, or hemoglobin of 6 to 10, causes cardiopulmonary symptoms, more cardiopulmonary symptoms such as palpitations, dyspnea, a roaring in the ears, and fatigue. In severe anemia, general manifestations include sensitivity to cold, weight loss, lethargy. Cardiopulmonary symptoms result from additional attempts by the heart and lungs to provide adequate oxygen to tissues. So we see tachycardia, increased blood pressure, pulse pressure, tachypnea, and dyspnea at rest. Cardiac output is maintained by increasing the heart rate and the stroke volume. And low viscosity of the blood contributes to the development of systolic murmurs and bruits. In extreme cases, or when the patient has underlying heart disease, angina or MA may occur. Skin changes include pallor from decreased hemoglobin as well as decreased blood flow to the skin. If the patient is having excessive red blood cell breakdown, they may have an increase in serum bilirubin, which causes jaundice, or an increase in serum and skin bile salt concentrations, which leads to pruritus or itching. Iron deficiency anemia is the most common nutritional disorder in the world and may develop due to inadequate dietary intake, malabsorption of iron intake, blood loss, or hemolysis. Normal dietary iron intake is adequate to meet the needs of men and older women, but it may be inadequate for individuals who have higher iron needs, such as menstruating women or women who are pregnant. Iron absorption occurs in the duodenum, so malabsorption syndromes may involve diseases of the duodenum in which absorption surface is altered or destroyed, which can occur after certain types of GI surgeries, such as the removal or bypass of the duodenum. Blood loss is the major cause of iron deficiency in adults. Major sources of chronic blood loss are GI and GU symptoms. GI causes of loss are peptic ulcers, gastritis, diverticula, hemorrhoids, and cancer. GU blood loss occurs primarily from menstrual bleeding, but can also be from chronic kidney disease, dialysis, and pregnancy contributes to iron deficiency because of iron diversion from the mother to the fetus, as well as blood loss at delivery and lactation. Typical manifestations of anemia, iron deficiency anemia, usually is asymptomatic early on, but they may develop paler, glossitis, which is inflammation of the tongue, cheilitis, which is inflammation of the lips, as well as headache, paresthesias, or burning sensation of the tongue. In evaluating all anemias, we're going to look at the hemoglobin and then the different indices of the red blood cells. For iron deficiency anemia, we expect to see a low hemoglobin as well as low iron stores. When the cause of the bleeding is not, cause of blood loss is not obvious, patients may also undergo a stool occult blood test, endoscopy, or colonoscopy to look for GI losses. The goal is to treat the disease causing the reduced intake or either causing the reduced intake or reduced absorption of iron, and then to replace iron, either through nutritional therapy, oral supplements, or transfusion of packed red blood cells if the iron deficiency is from acute blood loss. Iron is absorbed best from the duodenum, therefore enteric-coated or sustained release capsules, which release iron further down the GI tract, are counterproductive and expensive. The daily dosages provide 150 to 200 milligrams of elemental iron. This can be ingested in 3 or 4 daily doses. Iron is best absorbed as ferrous sulfate in an acidic environment, and for this reason, and to avoid binding of the iron with food, iron should be taken an hour before meals when the duodenal mucosa is most acidic. Taking iron with vitamin C or orange juice can also enhance absorption. Undiluted liquid iron is available but may stain teeth, and thus the reason for ingesting it through a straw. Side effects include constipation as well as a black tarry stool. Iron therapy for 2 to 3 months after hemoglobin levels return to normal is recommended. Iron can also be given parenterally, which is indicated for patients who have malabsorption, who will be unable to absorb the oral iron, or those with oral iron intolerance or poor patient compliance. Thalassemia is a group of diseases involving inadequate production of normal hemoglobin, which decreases red blood cell production. Thalassemia is due to an absent or reduced globulin protein. Either alpha globulin chains are absent or reduced, or beta globulin chains are absent or reduced. Hemolysis also occurs in thalassemia, but insufficient production of normal hemoglobin is the predominant problem. It is common in ethnic groups of the Mediterranean Sea or in the near equatorial regions of Asia, Middle East, and Africa. It has an autosomal recessive genetic basis. So an individual with thalassemia may have a heterozygous homozygous form of the disease based on the number of thalassemic genes that the individual has. A patient who is heterozygous has 1 thalassemic gene and 1 normal gene, and has thalassemia minor, which is a mild form of the disease. This patient typically has mild to moderate anemia, and usually does not require treatment. A homozygous person has 2 thalassemic genes, causing a severe condition known as thalassemia major. This is life-threatening. Symptoms typically develop by age 2 and can cause physical and mental growth deficits. As the bone marrow responds to the reduced oxygen carrying capacity in the blood, red blood cell production is stimulated. The marrow becomes packed with immature erythroid precursors that die, which stimulates further erythropoiesis, leading to chronic bone marrow hyperplasia and expansion of the marrow space. This can cause thickening of the cranium and maxillary cavities. Other symptoms include jaundice, splenomegaly, hepatomegaly, and cardiomyopathy. Cardiac complications from iron overload, lung disease, and hypertension contribute to an early death. The symptoms are managed with blood transfusions or exchange transfusions in conjunction with chelating agents to bind iron and reduce iron overload. Because red blood cells are sequestered in the enlarged spleen, Thalassemia major may be treated with a splenectomy. Megaloblastic anemias are a group of disorders caused by impaired DNA synthesis and are characterized by the presence of large red blood cells. The majority of megaloblastic anemias result from cobalamin or B12 and folic acid deficiencies. Cobalamin deficiency or vitamin B12 deficiency is the most common cause of is a deficiency in B12. The most common cause of B12 deficiency is pernicious anemia, which is caused by an absence of intrinsic factor, which is normally secreted by the gastric mucosa. Intrinsic factor is required for cobalamin absorption. In pernicious anemia, the gastric mucosa does not secrete intrinsic factor, either because of mucosal atrophy or autoimmune destruction of parietal cells. It can occur in patients with history of GI surgery, such as gastric bypass. Manifestations include sore tongue, anorexia, nausea, vomiting, and abdominal pain. They may also develop neuromuscular manifestations such as weakness, numbness of the hands and feet, decreased vibratory and positional senses, ataxia, muscle weakness, and impaired thought process. Parenteral or intranasal administration of cobalamin is the treatment of choice for B12 deficiencies, and that is a question on your test. Patients will die in 1 to 3 years without treatment. This anemia can be reversed with ongoing treatment, but long-standing neuromuscular complications may not be reversible. Folic acid deficiency is the other type of megaloblastic anemia. Folic acid is needed for DNA synthesis, leading to red blood cell formation and maturation. Common causes of folic acid deficiency include dietary deficiency, malabsorption syndromes, medications such as methotrexate and anti-seizure drugs, alcohol abuse, anorexia, and loss during hemolysis. Symptoms are the same as cobalamin deficiency with the absence of neurological deficits. In folic acid deficiency, the serum folate level is low with a normal serum cobalamin level. Replacement therapy is the treatment of choice. In patients with malabsorption states or chronic alcoholism, higher doses are required. Anemia of chronic disease is also called anemia of inflammation, and it has an immune basis. Cytokines released in various conditions cause an increased uptake and retention of iron within macrophages, which limits the iron which is available for erythropoiesis. We differentiate it from other anemias because patients typically have normal folate and cobalamin levels. Causes include HIV, hepatitis, malaria, heart failure, cancers, and bleeding episodes. Typically, this type of anemia is mild and treatment is based on correcting the underlying cause. If it is severe, blood transfusions may be indicated, but they are not recommended for long-term treatment. Erythropoietin therapy can also be considered for anemia related to renal disease, but should be used conservatively as there is an increased risk of thromboembolism in some patients. Aplastic anemia is a disease in which the patient has peripheral blood pancytopenia. As we discussed before, this means that they have low or a decrease in all blood cell types, including red blood cells, white blood cells, and platelets, and a hypocellular bone marrow. It can be a chronic disorder managed with erythropoietin and blood transfusions, or potentially fatal from hemorrhage and sepsis. Most are due to autoimmune activity by autoreactive T lymphocytes, where cytotoxic T cells target and destroy the patient's own hematopoietic stem cells. Patients are at an increased risk for infection due to neutropenia from low platelet counts, or an increased risk for bleeding events. Neutropenia from low white blood cell counts, and increased risk for bleeding events due to low platelet counts. Acute blood loss anemia occurs because of a sudden hemorrhage from trauma, surgery, or diseases that disrupt vascular integrity. Clinical concerns result from either a sudden reduction in total blood volume that can lead to hypovolemic shock, or if the acute blood loss is more gradual, the body maintains its blood volume by slowly increasing the plasma volume, but then the number of red blood cells is significantly diminished. It's essential to understand that clinical signs and symptoms the patient is experiencing are more important than the lab values we're seeing. For example, in a patient with a bleeding peptic ulcer who had a 750 milliliter hematemesis, so they threw up 750 milliliters of blood within the past 30 minutes, may have postural hypotension, but may have normal values of hematocrit and hemoglobin. However, over the next 36 to 48 hours, most of the blood volume deficit will be replaced by the movement of fluid from the extravascular into intravascular space. Only at the later times will the hemoglobin and hematocrit reflect the blood loss. Hemolytic anemia is due to destruction or hemolysis of red blood cells at a rate that exceeds production of red blood cells. It can be intrinsic or extrinsic to the cause can be intrinsic or extrinsic to the red blood cells. Intrinsic hemolytic anemia are usually hereditary, resulting from defects in the red blood cells themselves. More common causes are acquired hemolytic anemias, where the red blood cells are normal, but external factors cause damage. Hemolysis of red blood cells can be from physical destruction resulting from extreme force on cells, causing disruption of the red blood cell membrane, such as during hemodialysis or cardiopulmonary bypass. Antibodies may destroy red blood cells, and antigen-antibody reactions or infectious agents can also cause hemolysis. Jaundice is likely because of the increased destruction of red blood cells causes an elevation in bilirubin levels. Spleen and liver may become enlarged because of hyperactivity, which is related to macrophage phagocytosis of the defective erythrocytes. Maintaining renal function in hemolysis is a priority, and aggressive hydration and electrolyte replacement are needed to reduce risks of kidney injury. Sickle cell disease is a group of inherited autosomal recessive disorders characterized by the presence of abnormal forms of hemoglobin in the red blood cell. It is often fatal by middle age because of renal failure, infection, pulmonary failure, or stroke. Hypoxia or deoxygenation of red blood cells caused by infection or other stressful events trigger sickling of red blood cells. Okay, sorry about that. So hypoxia or deoxygenation of red blood cells caused by infection or other stressful events trigger sickling of red blood cells, where the red blood cells become rigid and take on elongated crescent shapes, as we see in the picture here. Sickled cells cannot easily pass through capillaries and cause vascular occlusion, which can lead to acute injury or chronic tissue injury. At first, sickling is reversible with reoxygenation, but eventually becomes irreversible due to cell membrane damage. Sickle cell crisis is a severe, painful, acute exacerbation of red blood cell sickling, causing vaso-occlusive crisis. So there is a question about this on your test. Sickle cell disease, the main symptom is sickling, associated with sickling is pain. Organs that need large amounts of oxygen are most affected, including spleen, liver, spleen, lungs, kidney, and brain. Hemochromatosis is an iron overload disorder primarily caused by a genetic effect, but may occur secondary to other diseases. Early symptoms are nonspecific, but later, such as fatigue and arthralgia, but later the excess iron accumulates in the liver and causes liver enlargement and eventually cirrhosis. Lab values demonstrate an elevated serum iron, total iron binding capacity, and serum ferritin. The goal of treatment is to remove excess iron from the body and minimize symptoms that patients may have. Iron removal is achieved by removing 500 milliliters of blood each week for 2 to 3 years until the iron stores in the body are depleted. Then blood is removed less frequently to maintain iron levels within normal limits. Oops, sorry. My slides aren't moving. Polycythemia is the production and presence of increased numbers of red blood cells, which can impair blood circulation due to increased blood viscosity and volume. There are two types, primary and secondary. Primary is a chronic myeloproliferative disorder and involves not only increased production of red blood cells, but also white blood cells and platelets. So splenomegaly and hepatomegaly are common. Secondary polycythemia is either hypoxia-driven or hypoxia-independent. In hypoxia-driven polycythemia, hypoxia stimulates erythropoietin production in the kidneys, which in turn stimulates red blood cell production. In hypoxia-independent polycythemia, cancer or benign tumor tissues make erythropoietin. Phlebotomy is the mainstay of treatment, and the goal is to reduce hematocrit and keep it less than 45%. There is a question about polycythemia on your test, and one of the major risks associated with increased levels of red blood cells in polycythemia is the risk for DVT or clots. Thrombocytopenia is a reduction in platelets below 150,000. Acute, severe, or prolonged decreases from normal range can result in abnormal homeostasis with prolonged bleeding from minor trauma, ranging all the way to spontaneous bleeding without injury. Platelet disorders can be inherited, but the vast majority are acquired. And a common cause of acquired disorders is medications. The cause of acquired disorders includes autoimmune diseases, increased platelet consumption, splenomegaly, bone marrow suppression, and bone marrow failure. The most common acquired thrombocytopenia is a syndrome of abnormal destruction of circulating platelets termed immune thrombocytopenia, or ITP. In ITP, platelets are coated with antibodies. They function normally. However, when they reach the spleen, they are mistaken as foreign and destroyed by macrophages. This can be caused by autoimmune diseases or infection. It usually presents as a chronic condition in adults, but as an acute condition in children secondary to viral infection. Thrombocytic thrombocytopenia purpura, or TTP, is an uncommon syndrome characterized by hemolytic anemia, thrombocytopenia, neurologic abnormalities, fever, and renal abnormalities. It's associated with enhanced aggregation of platelets, which form microthrombi. Can be autoimmune or due to drug toxicities, and it is a medical emergency because bleeding and clotting occur at the same time. Heparin-induced thrombocytopenia, or HIT, is platelet destruction and vascular endothelial injury are the two major responses to an immune-mediated response to heparin. It typically develops 5 to 10 days after heparin therapy is started and should be suspected if platelet counts drop 50% from baseline in a patient on heparin therapy. Venous thrombosis is a major clinical problem. Most common symptom is petechiae, or microhemorrhages, which we see in this picture. There can also be bleeding into the skin that forms bruises such as purpura or ecchymosis. We see prolonged bleeding after routine procedures such as blood draws, as well as hemorrhage. ITP is treated typically with platelet transfusions, although they can also be treated with corticosteroids, high doses of IV immunoglobulin or IVIG, and anti-RH, Rituxan, or splenectomy. Hemophilia, or von Willebrand's disease, is a defect or deficiency in coagulation factors. Hemophilia is an X-linked recessive genetic disorder caused by a defective or deficient coagulation factor, and the two major types are hemophilia A and B. Von Willebrand's disease is a related disorder involving a deficiency of the von Willebrand coagulation protein. In these disorders, any bleeding episode may lead to life-threatening hemorrhage, and the goal of treatment is to prevent and treat bleeding. Replacement of deficient clotting factors is the primary treatment. And the most common problems with acute management are starting factor replacement therapy too late or stopping it too soon. There are a couple of questions on your exam about these bleeding disorders. For von Willebrand's disease, when we are monitoring, the bleeding time is what we watch. Platelet counts, prothrombin time, and thrombin time are normal in von Willebrand's disease, but the bleeding time is altered due to the deficiency of coagulation protein. So for von Willebrand's disease, we monitor bleeding time. For hemophilias, there's a question asking about what would be most concerning. bruising, skin abrasions, bleeding gums, or tarry stools. While all of these are concerning in hemophilia, the most concerning is the tarry stools because it's a sign of gastrointestinal bleeding and requires collaborative actions such as checking hemoglobin and hematocrit, as well as administration of coagulation factors. So again, when it asks you which is the most concerning with hemophilia, all of those indicate bleeding and are concerns, but the most concerning is the tarry stools because it shows that there's a possible GI bleed. Disseminated intravascular coagulation, or DIC, is an abnormality in clotting followed by an uncontrollable hemorrhage. It is not a disease in itself, but an abnormal response from the normal clotting cascade stimulated by a disease process or disorder. Decreases in clotting factors and platelets ensue, which leads to uncontrollable hemorrhage. It is always caused by an underlying disease, and treatment is directed at correcting the underlying problem. And so you kind of see here in this graph that you have a depletion of coagulation factors and platelets, which leads to bleeding, while at the same time, you have intravascular deposition of fibrin and thrombosis of the small and mid-sized vessels, which leads to organ failure. And one of the things you may see patients present with is this necrosis of their fingers from clotting. Leukemia is a group of malignant disorders affecting the blood and blood-forming tissues of the bone marrow, lymph system, and spleen, which results in an accumulation of dysfunctional cells due to loss of regulation of cell division. And it's classified as either ALL, AML, CML, and chronic lymphatic leukemia. This just kind of shows the pathophysiology of how these immature white blood cells infiltrate. So we have in the bone marrow, we have failure of erythrocytes, lymphocytes, and platelets, which leads to anemia, immunosuppression, and bleeding or decreased clotting. And then we also have cell infiltrates into the central nervous system, the testicles, lymph nodes, liver, spleen, and joints. The presentation is varied, but is related to bone marrow failure. And so we have overcrowding of abnormal cells, which leads to splenomegaly and hepatomegaly, as well as inadequate production of normal bone marrow cells, which leads to anemia, thrombocytopenia, and altered white blood cells. So we have increased risk of bleeding, clotting, as well as increased risk of infection. Treatment includes chemotherapy as the mainstay, and the goal is to attain remission. Prognosis is directly related to the ability to maintain remission, and prognosis becomes more unfavorable with each relapse. Other treatments include corticosteroids, radiation therapy, immunotherapy, targeted therapy, and stem cell transplant. Hodgkin's lymphoma is characterized by a proliferation of abnormal giant multinucleated cells called Reed-Sternberg cells. The cause is unknown, but key factors are thought to be an infection with Epstein-Barr virus, as well as a genetic predisposition or exposure to occupational toxins. The disease likely starts in a single location and then spreads along adjacent lymphatics. It eventually infiltrates organs, including the lungs, spleen, and liver. Initial symptoms are enlargement of cervical and axillary or inguinal lymph nodes. Treatment is chemotherapy. Non-Hodgkin's lymphoma is a broad group of cancers of primarily B, T, and natural killer cells. B cell lymphomas constitute about 88% of non-Hodgkin's lymphoma. The cause is unknown, but again, is thought to be due to chromosomal translocations, infections, or environmental factors and immunodeficiency. With non-Hodgkin's, the spread is unpredictable, and most patients have widespread disease at the time of diagnosis. Primary symptoms, again, are lymph node enlargement. Treatment involves chemotherapy, biotherapy, radiation, and sometimes phototherapy or topical therapy. The more aggressive the lymphoma, generally the more responsive they are to treatment, although unfortunately, complete remission with non-Hodgkin's is very uncommon. Multiple myeloma is a condition in which cancerous plasma cells proliferate into the bone marrow and destroy the bone. In multiple myeloma, instead of a variety of plasma cells making antibodies to fight different infections, myeloma tumors make monoclonal or all one kind of antibodies, which makes them not only ineffective, but also harmful. So not only do these antibodies not fight infections, but they infiltrate the bone marrow. The cause is unknown, but possibly due to exposure to chemicals such as herbicides, insecticides, or from viral infections. Typically, patients do not have symptoms until the disease is advanced, in which case skeletal pain is the main symptom due to diffuse osteoporosis and osteolytic lesions. There is a question on the test about multiple myeloma. As the bone is destroyed, elevated calcium levels become a concern. Possible complications from hypercalcemia include seizures and dysrhythmias. Treatment for multiple myeloma include chemotherapy, immunotherapy, targeted therapy, and corticosteroids. We talked about several conditions that can cause splenomegaly or enlargement of the spleen. It can be caused from congestion, from things such as cirrhosis of liver or heart failure or sickle cell disease. It can be caused by infections such as bacterial, fungal, parasitic, or viral, or autoimmune diseases such as lupus or rheumatoid arthritis. It can also be caused by infiltrative tumors or diseases such as leukemia or lymphoma. When the spleen enlarges, its normal filtering and storage capacity increases, and consequently, there is a reduction in the number of circulating blood cells because they're all being stored up in the spleen. Patients may complain of abdominal discomfort or early fullness because the spleen is located right by the stomach. Occasionally, splenectomy is done as a treatment, either for splenomegaly or due to splenic rupture. There is a question on the exam about splenectomies. So after splenectomies, immunological deficiencies may develop, and patients have a lifelong risk for infection from encapsulated organisms such as pneumococcal species. So in a patient with splenectomy, it is very important that they receive a pneumococcal vaccination. So mark that down, it's on the test. And the last slide here is just about blood component therapy. So administration we can give to treat these hematologic diseases or manage them, So these are used to manage, not treat. They temporarily support the patients while we treat them for their underlying issues. So we can give whole blood, packed red blood cells, platelets, or plasma. Auto transfusions are transfusions from the patient to self. So we give those when we know there's going to be blood loss, like after a surgery. We'll first, a few weeks before, pull the patient's own blood. It can be stored and frozen for up to a couple of years. And then when the patient needs it, we can transfuse it back in. That's the safest because we don't have to worry about compatibility issues or antigens or antibodies. But when we receive from a donor, there is concern for blood transfusion reactions, which can be acute or delayed. There is a question about blood transfusion reactions. If a transfusion reaction is suspected, the first step is to stop the transfusion. Then we want to make sure that we maintain an IV line, notify the blood bank and the healthcare provider. We're going to recheck identity tags and numbers to make sure we're giving the right patient the right product. We're going to monitor vital signs as well as urine output, treat any symptoms per healthcare provider order. We're going to save the blood bag and tubing and send it to the blood bank, as well as collect any blood samples and urine samples, and then lastly, document. In the test, the specific question is about a patient who presents with back pain and difficulty breathing 15 minutes into administration of packed red blood cells. So if that patient presents to you, they're receiving blood cells, they have back pain and difficulty breathing, the first most important step is to disconnect the transfusion. Okay, thanks guys.